Hello, guys. So today we are going to discuss the topic of dizziness. Dizziness can be a very confusing term used by different patients. Different patients use different terms for dizziness. For example, the patient can complain of giddiness, head spinning, whirling, swinging, fainting. These are some of the terms which can be used by the patients when they are describing dizziness. So, to aid our diagnosis, we can differentiate dizziness. John Murtagh has classified dizziness as pseudo vertigo and vertigo. Vertigo is actually the episodic sudden sensation of circular motion of the body and the surroundings. And pseudo vertigo can further be classified into giddiness, which is actually the ill-defined lightheadedness, fainting, and syncope, which can lead to impending loss of consciousness, and disequilibrium, which is the loss of balance while walking, and it is usually neurogenic in nature. Now, how we are going to reach the diagnosis, we are going to follow the diagnostic model. In diagnostic model, first of all, we have probable diagnosis. What can be the probable diagnosis a doctor can think of when the patient complains of dizziness? Most of the times, it can be associated with anxiety or hyperventilation. Postural hypertension is one of the most common causes of dizziness. The patient can have simple faint, which is the vasovagal response, acute vestibulopathy, benign paroxysmal positional vertigo, motion sickness, vestibular migraine, cervical dysfunction. Dizziness can be associated with some of the serious disorders. So some of the serious disorders which we should keep in mind when the patient is complaining of dizziness, these can be cancers like acoustic neuroma and posterior fossa tumors, intracerebral infections like abscess, cardiovascular diseases like arrhythmias, myocardial infarction, aortic stenosis, Stokes-Adam attack. In cerebrovascular, the patient can have vertebrobasilar insufficiency, brainstem infarct, like posterior intracerebral artery thrombosis, multiple sclerosis, carbon monoxide poisoning. Now we have the pitfalls. These are the disorders which often get missed, and they are not given much importance while diagnosing. These can be earwax, autosclerosis, arrhythmias, hyperventilation, usage of alcohol, severe cough, and Meniere disease. Meniere disease, actually, most of the times it is overdiagnosed. Now we have the seven masquerades. In seven masquerades, depression can be one of the causes of dizziness. In diabetes, if the patient has hypoglycemia, and especially if the patient is on anti diabetic drugs, hypoglycemic agents. Some of the important drugs like anti-epileptics, antihypertensive, antidepressants, and antibiotics like ciprofloxacin, streptomycin, these can cause dizziness. If the patient has decreased hemoglobin, he can, like in anemia, the patient can have dizziness, thyroid disorders, and spinal dysfunction like cervical dysfunction. So now coming towards red flags, which is the very important part, and the AMC test you on these uh, mm, headings, like if the patient is having dizziness and he has some of these red flags, it can point towards some of these serious disorders, and these red flags should never be missed. For example, if the patient has some neurological signs associated with dizziness, ataxia, which is out of proportion to vertigo, means that ataxia is more severe than vertigo, and the patient has nystagmus or central nystagmus on examination, and he has central eye movement abnormalities. So these are the red flags. Now coming towards vertigo. Vertigo is actually classified into central vertigo and peripheral vertigo. The central vertigo can present with number of other symptoms like ataxia, diplopia, slurred speech, swallowing difficulty, abnormal eye movements. And what are the causes of central vertigo? Most of the times it is neurogenic. Central vertigo is actually neurogenic. Like if the lesion lies in brainstem, like in transient ischemic attack or stroke, vertebrobasal insufficiency, and posterior intracerebral artery infarct. In cerebellum, the cerebellum has degeneration, and there are some tumors. The patient can have migraine or multiple sclerosis. These are the cause of central vertigo. Now coming towards peripheral vertigo is associated with hearing loss, tinnitus, ear fullness, and positive head impulse test. In the causes of peripheral vertigo can be lying in labyrinth. If the origin of peripheral vertigo is labyrinth, these can be caused by labyrinthitis. And Meniere disease, benign paroxysmal positional vertigo, drugs, trauma, chronic otitis media, and the lesion of eighth nerve can also cause peripheral vertigo, like vestibular neuronitis, acoustic neuroma, and certain drugs which affect eighth nerve. Now, what are the causes of vertigo in children? In children, the most common cause of vertigo can be seizure, which is where when the focus lies in temporal area, and some vertigo in children can point towards certain and some serious disorders like tumors or medulloblastoma of children is very common in children. It can present with vertigo, and vestibular migraine and infections, benign paroxysmal positional vertigo. Now coming towards individual causes of dizziness and vertigo. On First, we have lateral medullary syndrome. Lateral medullary syndrome is caused by posterior inferior cerebellar artery thrombosis, which is pica, and it can present with severe vertigo, and cerebellar signs would be there, ataxia, and vomiting can also be there. The patient would be having ipsilateral cranial nerve signs would be ipsilateral, and spinothalamic sensory loss of face and body would be contralateral. Right now, coming towards acoustic neuroma. Acoustic neuroma is suspected in patients who present with a diagnostic triad of unilateral tinnitus and hearing loss, unsteady gait, and vertigo. So we are going to suspect acoustic neuroma if these are the symptoms. Now coming towards acute vestibulopathy. Acute vestibulopathy, in which we have neuritis. Vestibular neuritis can be neuronitis and labyrinthitis. Neuronitis, the patient would be having acute vertigo and nausea and vomiting. In labyrinthitis, there would be acute vertigo, nausea, vomiting. The patient would also be having hearing loss and tinnitus. And in acute vestibulopathy, the patient would be having preceding flu-like symptoms. Benign paroxysmal positional vertigo BPPV, and this is a very common disorder of vertigo, and it is actually presented with episodes of acute vertigo with most of the times suddenly changing head position, and the patient is also having nausea. Vomiting is not most of the times present in benign paroxysmal positional vertigo. Nausea would be there, and each attack would be lasting for 10 to 60 seconds, and patient is scared to suddenly stand up or sitting from lying position and suddenly changing head position. And the predisposing factors would be most of the times there are no predisposing factors. Viral labyrinthitis can be one of the causes, one of the predisposing factor, and trauma. Meniere syndrome or Meniere disease is usually presented in 30 to 50 years of age, and these are actually paroxysmal attacks of vertigo, tinnitus, nausea, and vomiting, sweating, pallor, and there is progressive deafness, sensory neuronal progressive deafness, and the attacks of Meniere syndrome last from 30 minutes to hours, and there is nystagmus during attack. Actually, there is a buildup of endolymph. It is Meniere syndrome is actually due to the buildup of endolymph, and the management lies in decreasing the endolymph. If we decrease the sodium and water level of endolymph by diuretic, and diuretic is given as prophylaxis for Meniere syndrome. Vestibular migraine is also very common, and mostly patients have vestibular migraine who are having vertigo. There would be history of migraine in past or family, and the vestibular migraine would be presented with a history of recurrent bouts of spontaneous vertigo or ataxia. So another thing which is very important for EMC MCQ exams is that when are we going to refer the patient to a specialist? When the diagnosis of vertigo is uncertain and it is presented in children, there is tumor on investigation, vertigo is followed by trauma, viral labyrinthitis, which is not resolving in 3 months, Meniere syndrome, which is not responding to conservative treatment. There is evidence of vertebro-basal insufficiency. There are other neurological signs and symptoms. BPPV is more than 12 months despite repositioning exercises. So these are some of the points when we are going to refer the patient to the specialist. That's it for the dizziness. Thank you.